It's my pleasure to have all of you here with us in this webinar, which is considered as a pre-Congress event in relation to the International Society of Gynecological Endocrinology Congress of Florence. This afternoon, we have a fantastic talk between two members of the board, Professor Martin Birkhauser, which is Professor Emeritus University of Bern, and he has been head of the Division of Gynecological Endocrinology and Reproductive Medicine at University of Bern until December 2008. And he's one of our members and also is the treasurer of the Gynecological Endocrinology Society. The other panelist is Professor Alfred Muck. Alfred Muck is have a specific position not only in our board, but also he is professor of endocrinology, biochemistry, and clinical pharmacologist at University of Tübingen, and is also professor of reproductive endocrinology at the Capital Medical University in Beijing, in China. He has the double position, and is also guest professor of Zhejiang University in China. And he also is speaking Chinese, but this afternoon he will make the lecture in English, I suppose. And then, dear friends, we have now to start, and our first lecturer is Professor Martin Birkhauser. Please, Martin, can you share your screen? And then we will start. We will have the two lectures, and then we will have a session of question and answer. Please, to everybody, write your question in question and answer, and then I will manage the general discussion. Professor Martin Birkhauser.
Good afternoon, everybody. As I said, I have no contact interest declare, and we have to start with some basic knowledge or to repeat it because you know it already. First of all, estradiol is not identical to estrogen estradiol. The half-life of estradiol 17-beta is about 15 minutes. The one of estrogen estradiol is about 12 to 15 hours, much, much longer. And that is due to the fact that estradiol 17-beta is metabolized to estrone, but this metabolization is blocked in EE by the estrogen group at position 17. This group does not allow the oxidation to estrone as it is normal for estradiol 17-beta. The consequence is that EE is much more powerful, and among others, it has a much higher impact on hepatic proteins such as SHBG or coagulation factors or angiotensin, all factors important in the risks in oral contraceptive uses. Sorry. The next point you have to respect is the different partial activities of progestogens. You all know the definitions by generations, but generations are a marketing instrument and not instrument that characterizes really progestogens. You have here in green the classical progestogens. Sorry, it moves right alone. Like levonorgestrel, norgestimate, and the new one that are not in green, they have not the same risks. Levonorgestrel and norgestimate are, as we see later, the much more favorable progestogens if you want to avoid risks. So generations alone do not say all that we have to know about progestogens. The next point to see first is the definition of the UCMEC categories. UCMEC means UK Medical Eligibility Criteria for Contraceptive Use. Category 1 is a condition for which there is no restriction for the use of the method. Category 2, a condition where the advantages of using the method generally outweigh the theoretical proven risks. Category 3 is a condition where the theoretical or proven risks usually outweigh the advantages. And category 4 is a condition which represents an acceptable health risk if the method is used. You'll find these categories all through my lecture. Then for some methods, we have to distinguish between initiation and continuation of the method. It is not always identical. The last point to see first is the causes of death in women. I take here European countries. Coronary heart disease, cerebrovascular accident, and other vascular diseases are the most important cause of death. The three together represent 55% of all causes of death. The second category is cancer, together 70%. And then we have some other points like respiratory diseases with 6%, accidents and poisoning 4%, and some isolated causes together 16%. So we concentrate, of course, at the most important cause of death, that is the vascular risks. Let us start with arterial risk. We take stroke and myocardial infarction together, as is done by some Cochrane analysis. The big four risk factors are age, weight, smoking, and hypertension. A woman having one of these risks or several together has an increased risk if she uses combined hormonal contraceptives. Here you see the spontaneous evolution of MI and cerebrovascular accidents in proportion to age. If you take both MI and CVI, you see that the risk starts to increase in the late 30s. Next slide shows smoking and its impact on MI. On the slide, you have always in blue the smokers and in gray the non-smokers. If you go to the younger ages, 30 to 39 years, we recognize that in non-users, the risk increases by smoking alone. But if you add a combined hormonal contraceptive to smoking, the risk increases about 10 times. That means you have 10 deaths by myocardial infarction per year per 100,000 women. To the right, you have the age group 40 to 44 years. Look at the scale. The scale is 10 times higher than to the left. And there you see a very high increase in women using CHCs and smoking at the same time. That is the group here. There we have in women smoking and using COX a risk of about 62 deaths of myocardial infarction per year per 100,000 women. What about blood pressure? Again, in light gray, women without hormonal contraception, and in dark gray, users of CHCs. If you go to the young age group, the risk increases by the use of CHC, but the absolute risk stays low. If you go to the age group of 35 to 44, and you take first the non-users of CHC, you have a hypertension in these women of about 2 to 3%. If you go to the use of COX, this percentage doubles to about 5% of all women tested. So CHC use is a risk factor for hypertension, and hypertension is a risk factor for MI, as we know all. What says UCMEC? If somebody has adequately controlled hypertension, the factor put by UCMEC is 3, that the risks means the risks are higher than the advantages. If a patient has a systolic blood pressure moderately elevated, that means diastolic pressure is between 90 and 99 millimeter mercury, then you have a 3. If the blood pressure is higher, above 100, in systolic blood pressure, it's a 4. That means for these women, it's an absolute no-go to use CHCs. If you look at CVD specifically, and we take a woman having risk factors for cardiovascular disease, might be smoking, diabetes, hypertension, obesity, or dyslipidemia, then you have 3 for the users of CHC, a 2 for progesterone-only pills, for DMPA it's a 3, for the other potency principles a 2, and for copper IUD a 1. For known dyslipidemias, you have a 2 in general. For women having a pathologically high cholesterol level, for instance, it can be more, it can be a 4. For the other principles, progestin only, it's a 2, and copper IUD again a 1. If a patient has a cardiomyopathy with a normal cardiac function, it is a 2 for CHC and a 1 for all other principles. If there is impaired cardiac function already, it's a 4 for CHC and a 2 for the other principles, meaning the advantages are outweighing the risks. A patient with atrial fibrillation has a 4 for CHC because of the coagulation risk and embolism, a 2 for progestin-only principles, and a 1 for copper IUDs. A long-QT syndrome puts us a 2 for CHC, a 2 for DMPA, and a 1 for progestin-only principles such as POP or implants. Interesting enough, for copper IUDs and normal and LNG IUDs, it is a 3 for the initiation of the method. Let us look now at the history of hypertension, history of diabetes, and family history of stroke and their impact on the risk in CHC users. If you have a history of hypertension, the risk increases by a factor 3 to 4. The 3.4 in Europe, that is significant, and in developing countries, about 5, significant too. History of diabetes increases the risk in Europe, but not significantly. In developed countries, it's 4 as a risk factor, and this is significant. A history of rheumatic heart disease is 2.5 in Europe, not significant, and 100 in developing countries. Family history of stroke increases the risk in both regions, significantly only in developing countries. Current cigarette smoking, of course, has an increase in both regions, significant. And hypertension during pregnancy, you have to think of that, increased risk too, and that is significant in both regions. So all these anamnestic factors and current cigarette smoking are increasing the risk in women taking CHCs. That is an interesting slide. Sorry, it went away. It shows the impact of different progestins on the risk in CHC users. Levonorgestrel, norgestimate, and NITA, all in the green part, have no increased risk in CHC users. Desogestrel, gestodine, drospirenol, and cyproacetate have an increased risk. Gestodine and drospirenol are both significant. Desogestrel in this study is not significant, and cyproacetate just at the limit. So if you look at this analysis, that is a Cochrane analysis by Roche, we should use, if you want to be at the safe side, one of the progestins within the green part of the slide. What about arterial diseases and CHC? We have for all vascular diseases altogether a 4, a no-go. For history of high blood pressure during pregnancy, a 2. We have seen already a similar slide. The current and history of ischemic heart disease is a 4. And the history of stroke, including TIA, is a 4 too. So these are high-risk conditions. Let us pass now to the venous risk. Again, the spontaneous evolution. In contrast to the arterial side, the venous thrombosis starts to increase already at a young age, and it increases more or less homogeneous. Here you see the importance of age and BMI for the risk in COX users in this slide. If you go to age, on this side, you have a low risk for low age, and the risk increases by age alone to about 18 events of VTE per 10,000 women years. If you take BMI alone, high BMI increases the risk to about 12, 13 VTE per 10,000 women years. And if you take both together, high age and high BMI, you reach a risk of about 25 to 30, depending on the study, events of VTE per 10,000 women years. So age and BMI together increase the VTE risk considerably. What says UCMEC for the use of CHC with VTE and obesity? A history of VTE is a 4 for CHC. Current VTE, even on anticoagulants, is a 4. Family history, first degree relative below the age of 45, a 3. Family history above 45 years, a 2. Major surgery and immobilization, a 4. Major surgery without immobilization, a 2. Minor surgery, 1. And immobility, unrelated surgery, accident or anything else, a 3. If you look at obesity, a body mass index of 30 to 34 is a 2, and a body mass index of 35 and above is a 3. So you shouldn't give a CHC. Is varicosis a risk factor? Varicosis alone? UCMEC says no, varicose veins alone does not increase the risk. If a woman has superficial venous thrombosis, it's only a 2. That means the advantages still outweigh the risks. But if you have a known thrombogenic mutation, it is a 4. Here an example, factor V Leiden. If a patient has no contraceptives and no factor V Leiden, the risk is low. If you have all contraceptives alone and no factor V Leiden, the risk is increased by a factor of 3. If you have no all contraceptives, but you are suffering from a factor V Leiden mutation, it is an augmentation by about 4. And if you have both together, all contraceptives and factor V Leiden, you have a risk of about 28.5 events per 10,000 person years. So that is considerable. Therefore, the 4 given by UCMEC is fully justified. If you compare it, we compare the DVT risk for different modern CHC used in Europe, we can get the following image. The two statistics taken are taken from Martinez and from the PROC. That is the EMA position statement of October 2013. You have in both analyses a low risk, but still elevated compared to the no use of CHC for levonorgestrel. You have a higher risk for gestodine and desogestrel. You have it here again, and drospirenone. In this study, you have an increased risk for etonegestrel and norepinephrine. This conclude that two statements conclude in the recommendation that you should use, if you want to be on the safe side, levonorgestrel, norgestimate, or noreltestrone. And here you have the statement of Lidegaard based on a Danish study. He says, compared with non-users of hormonal contraception, current use of all contraceptives with levonorgestrel had a 3-fold increased risk, and those using all contraceptives with desogestrel, gestodine, drospirenone, or saccharine acetate, a 6 to 7-fold increased risk. Again, the same conclusion. If you want to be on the safe side, you should use one of the classical progestins, such as levonorgestrel. Now we come to other conditions with an increased risk in CHC users. What about diabetes and below rheumatic diseases and viral hepatitis? In diabetes, history of gestational diabetes does not increase the risk for any method. If you have a diabetes without vascular diseases, independently, if you have a non-insulin dependent or insulin dependent diabetes, it's a 2 for combined hormonal contraceptives, a 2 for all progestin-only methods, and a 1 for kappa IADs. If the patient has a diabetes with nephropathy, retinopathy, or neuropathy, it becomes a 3 for combined hormonal contraceptives. If you have any other vascular disease in diabetes, it's a 3, 2. For these 3 categories, you should consult the specialist, or the patient should consult the specialist before we decide on the method of contraception. What about rheumatoid arthritis? A 2 for all hormonal principles, a 1 for cup IUDs. If a patient has a systemic lupus erythematosus without antiphospholipid antibodies, it is a 2. If there are the presence of antiphospholipid antibodies, it's a 4. If a patient has a positive antiphospholipid antibody test without a systemic lupus erythematosus for another reason, it's a 4, 2. These patients too should consult a specialist before you take a decision about the contraceptive method. Hepatitis has a 3 if there is acute hepatitis or a flare of hepatitis. For initiation, a 2 for continuation. A carrier has no restrictions, and chronic hepatitis has no restriction. Then we have some neurological conditions, especially headaches. If there is a headache not of the migraine type, you have a 1 for initiation, but if the headache continues in CHC users, it's a 2. If you have a migraine without aura at any age, it's a 2 for initiation, and a 3 if the migraine continues in CHC users. As soon as there is an aura, it becomes a 4 for combined hormonal contraceptives. And if a patient has a history of migraine with aura 5 or more years ago, it's still a 3, not recommended. Idiopathic intracranial hypertension is rare. It is a 2, so you can give a pill. The advantages are still higher than the disadvantages. What about breast? If there is an undiagnosed mass of breast symptoms, you should do an investigation first before you start the initiation of a contraceptive hormonal method. If you have already CHC in a patient, if she's a user, for the continuation, it's a 2. For all other conditions, benign conditions, or family history of breast cancer, it's a 1, except for carriers of known gene mutations, for instance, PRAP1 or 2. Then it's a 3 for CHC. That means the advantages are less important than the disadvantages. For current breast cancer, it's 4 for all hormonal methods, that's evident, 1 for cup IUDs, and for past breast cancers, it's a 3. That means in some rare exceptions, you can use CHC if the oncologist treating the patient agrees. Then bone and combined oral contraception, a special case. We know that neoprogestins possess a strong anti-gonadotropic activity. We know that combined oral hormonal contraception preparations containing low-dose EE combined with modern progestin and DMPA both suppress the hypothalamic pituitary ovarian axis despite the low EE content, so that in adolescence, endogenous estradiol production is decreased to peri- and postmenopausal levels and that reduces bone formation. Therefore, low-dose oral contraceptive use and DMPA might interfere with normal acquisition of peak bone mass when given early after menarche. And that means you shouldn't use these 2 principles, low-dose EE pills and DMPA, in adolescence before peak bone mass has been fully acquired. Newly introduced in the EUCMEC recommendations are 2 conditions: history of bariatric surgery. That depends on the body mass index. If the body mass index is still increased, it's a 2. If it is highly increased, equal or over 35, then it's a 3, not recommended. Organ transplant patients, if it is uncomplicated, you are allowed to use all methods, including CHC. It's a 2 for these methods. If it is a complicated evolution, it's a 3 for CHC and a 2 for other methods. It's a 3 for the initiation of cup IUD principle or LNG use. I come to the conclusions. We have to recognize that most trials of new contraceptive methods deliberately exclude women and subjects with chronic medical conditions. So we have little direct evidence. You have seen that in my lecture. Then we have to see that the initiation is different from continuation in some cases. In some conditions, CHC may only be initiated if the responsible GP or specialist agrees. Some medical conditions, especially myocardial infarction, stroke, and VTE, are associated with potential theoretical increased health risks when CHC are used. That means that in women at risk, CHC should not be used. Then, in some women at risk, non-hormonal alternatives to CHC, such as cup IUDs, should be preferred. Then we have important conclusion of the author of the Cochrane analysis looking at COX and myocardial infarction and stroke. This analysis shows that the risk of myocardial infarction and ischemic stroke was only increased in healthy women using COX with 50 or more micrograms of EE. Regarding myocardial infarction and ischemic strokes, prescribing COX with less than 50 micrograms of EE seems safe. The risks did vary according to the progesterone type, as you have seen on the slide I have seen before. Two basic rules: blood pressure, weight, smoking habits, and serum cholesterol have to be checked before the first initiation and each time that a new episode of CHC use is started. And the second basic rule: what about the non-contraceptive benefits of CHC? For the initiation of CHC in women at risk, the potential side effects always outweigh the potential non-contraceptive benefits. That is especially important if you use modern progestins having an increased risk for TVE. May 17-beta-estradiol and estradiol containing CHCs lowered the risk in CHC use. The preclinical data look mostly favorable, but we don't have enough clinical data to recommend already today 7-beta-estradiol or estetrol containing CHCs for women at risk. And then you have also remember that correlation is not always causal. Here you see the decrease of breeding storks, and here you see the decrease of live births in Baden-Württemberg. The relation is highly significant, but there is no causal relation. Thank you for your attention.
Thank you very much, Martin, for the beautiful lecture on high risk in contraception, in high-risk women who have to face the problem of contraception. I would like now to invite all of you to send your question through question and answer. We have already received from Marcus Sachensmeyer a question. The answer will be given at the end. And we have also other question coming from unknown, from anonymous person. Then now it's my pleasure to invite the second lecturer, which is Professor Alfred Mück, who will touch about another high-risk group, which is the perimenopausal group. Thank you, Alfred, and then you have the microphone, please.
Okay, can you see my slides?
Yes, perfect.
Okay, first I thank you, Andrea, for inviting me to this webinar, and I will continue with the contraception, and I will concentrate especially in perimenopause. So I am speaking especially in normal, on the question if normal women without special risks can use oral contraceptives. In some countries, like in the Scandinavian countries, they tell us that only oral contraceptives with norethistone or levonorgestrel should be used. So it is not quite clear if we really can use in perimenopausal normal women the oral contraception. So I will especially speak about question perimenopause, and I will speak if oral contraception can be used in perimenopause, and I will not so much speak about patients. If you have patients with special risk factors, I refer to the lecture which we have just heard from Professor Birkhäuser. So I will first start with some epidemiology. How is the use of contraceptives in the different countries? And the second part, the WHO, it was covered by Professor Birkhäuser. I can make it very briefly. The non-contraceptive benefits of COC, what was mentioned in the last part of Professor Birkhäuser, is important because COC, oral contraceptive, have non-contraceptive benefits in contrast to progestin-only pills, or in contrast to IODs, which have not those non-contraceptive benefits. So this is an important issue. So for the chapter 4, we have special concerns in perimenopausal women because it is very important to avoid pregnancy in perimenopause. And because I'm working in Europe and also in China, and I know that we have always participants of China. Also now, I will speak that there is a difference in the guidelines and in the recommendation. Now for the different countries, it is quite clear that Italy, USA, Germany, they use much of this COC. When you go to China or to Japanese, then the COC use is less than 3%. Depends, however, on the department. Working in China, in my department, in whole China, we have 2%, but in our department, we use about 30 to 40%. This is the same like in Germany. Then the use is dependent on the age. We have a decrease of the use of COC, combined oral contraceptives, with increasing age, but we have still about 30 to 35% in the perimenopause. So COC are used in perimenopause, but as I told you, in some countries, there are questions if COC could be used. Now, the next is that the WHI criteria with special importance in perimenopause are those criteria which especially are important for women who are coming older, like with hypertension, like with obesity. And there we use also the MSC, which you just have heard from Professor Birkhäuser. And the COC, combined oral contraceptives, mostly have to be compared with the risk of POP, progestin-only pills, or with the IUD. And one example in the arterial system is that COC can be used in hypertension with 3, but cannot be used with a high risk of venous thrombosis. And I can tell you that the risk of venous thrombosis is the decisive question about the use in perimenopause also of normal women, because we have an increased risk of VTE, of VTE, venous thromboembolism, already with age, already with normal women, maybe only some obesity. So the question of VTE risk is decisive for perimenopause, and it is especially decisive for women who have additional risk of venous thrombosis, like factor V Leiden mutation. As you can see here very clear that it is absolute contraindicated to use COC, or also the patch or the ring, where also ethinyl estradiol is inside. There is a 4, but you can use all progestin-only preparations, factor V Leiden mutation. So again, VTE risk is very important in the decision of the use of contraceptives in normal women. And I repeat, if you have risk patients, then you have also to consider the arterial risk, myocardial infarction. One of the last slides of Professor Birkhäuser was that in normal women, myocardial infarction and stroke is not a problem, but maybe VTE risk. And as I told you, it is important to consider the non-contraceptive benefits, especially of combined oral contraceptives, because these benefits have not progestin-only pills and have not the LNG, not the IUD with LNG. So the benefits of CUC in the decision, should we use CUC in perimenopause, yes or not, are very important. And first to say, it is very important to avoid pregnancy in perimenopause, because every pregnancy in perimenopause could be a risk pregnancy. So it is important to have a good contraceptive efficacy, which of course have CUC. The PUP, progestin-only pills, have also good efficacy, but the efficacy is really dependent on the use of the progestin-only pills. So they are not so good for contraception compared to CUC. And then we have the large list of non-contraceptive benefits. If women come in perimenopause, they mostly come with cycle disturbances. So if we can use CUC to get a good cycle stability, it is a large advantage. Some people also have acne hirsutismus, especially if they have PCO syndrome, etc. But more important for perimenopause is there is an increased risk of ovarian follicle cyst and also an increased risk of carcinoma of endometrium and colon carcinoma. So these benefits, the non-contraceptive benefits, are important in the decision, should we use CUC, yes or not. Now we have special concerns in the perimenopausal women. The first is, as I already told you, every pregnancy is a risk pregnancy or could be a high-risk pregnancy. So it is important to avoid pregnancy. And we cannot exclude pregnancy even in older women, and it is very difficult to have any laboratory test to decide if the people can got pregnancy or not, as we all know. So to avoid pregnancy is important. And we should also think that the thrombotic risk during a pregnancy is higher than the risk during all forms of hormonal contraception. If we have no pregnancy, the risk per 10,000 is about 1 to 5, and you can see in pregnancy is up to 20, and postpartum maybe up to 60. So to avoid pregnancy is also to avoid VTE risk. Another problem, especially in perimenopause, besides bleeding problems, almost every perimenopausal women have bleeding problems because we see the perimenopausal women looking at the bleedings. Another problem is they can start with climacteric symptoms with vaginal dryness, and they can start with bone loss. And if we use progestin-only pills or use the IUD, we have no effect on climacteric symptoms and on bone loss. And it could take long time to treat bleeding problems with LNG IUD. So sometimes 3 to 6 months in perimenopausal women. So this is a special concern. And another concern is, of course, women get older, they get more obesity, hypertension, metabolic change. And these are now the women, the patients where we should should make a contraception according to the presentation of Professor Birkhäuser. But the VTE risk is increasing also in mostly normal women. So again, the VTE risk is very important. It's the slide you have already seen. With increasing age, we have a strong increase of VTE risk. Now there is a dependency of type and progestogen, which you have seen in the presentation of Martin Birkhäuser, but and we have also in the labeling this dependency that we should use in patients with increased risk levonorgestrel, and this list is now in the labeling of most contraceptive pills, and we have until now, no data, or we need more data to CMA and to normegestrol acetate. And since 2 years, we have data to DNOGEST, and DNOGEST is now also classified in the group of progestins with higher risk. In Germany, you get a so-called warning red hand letter if something is important for the clinical practice. And they warned us in December 2018 that there are 4 observational studies that we have also an increased risk with DNOGEST. So DNOGEST is in the same group like cyproterone acetate or desogestrel. But I have to stress a very important thing. These lists, which we have like this in the labeling, are lists which are for contraceptive combined pills, not for progestin only pills. We have no real data that progestin only can increase the risk of VTE. So for progestin only, we can use all, until now we have only the desogestrel, soon prosperinone, progestin only will coming. So all what we hear about risk of VTE is related to combined risk, and is related mostly to combined risk with ethinyl estradiol. All the studies have done, with one exception, with ethinyl estradiol, and ethinyl estradiol have 2 main problems. First, there is an ethinyl group. This group is very active in the liver. So it can activate clotting factors in the liver, in contrast to estradiol. The only difference between this ethinyl estradiol and estradiol is this very aggressive group. This group is also responsible for drug interaction with, and when we have that, not this group, and when we use estradiol, we have less risk also of drug interaction. So this ethinyl group is the first reason for much higher hepatic efficacy of ethinyl group. The effects of ethinyl estradiol are about 500 times greater compared to estradiol. Now, the second reason why ethinyl estradiol is a problem is because ethinyl estradiol is stable. Half-lives are about 20. It depends on the study. So we have many passages through the liver until ethinyl estradiol, is metabolized. I have calculated that we need at least 20 liver passages to get EE levels lower than 5 picogram, which no longer is effective in the liver, for example, in the clotting system. So the second reason for the strong efficacy of ethinyl estradiol is that we have many liver passages. When we compare with estradiol, then it is totally others. Estradiol has a very short half-life. When we give estradiol orally, it goes to the liver, and within 5 minutes, the estradiol is metabolized to more than 90% to estrone, and only 5% of the estradiol goes to the systemic circulation. So within 5 minutes, estradiol is in the circulation, and the liver gets only 5 minutes the estradiol. And because the estradiol is only short time in the liver, it has less activity in the liver. And another thing is, of course, that we have also advantages of ethinyl estradiol. In the recent 50 years, almost all COC contained EE, and just until today, we have only 2 preparations based on estradiol, containing estradiol. The reason is because ethinyl estradiol is very stable, it also is stable in the endometrium. Can stabilize the proliferation, not up and down proliferation. It's not metabolized very fast. And we have if you have a stable proliferation, you have no breakthrough bleedings. That means you have very good cyclical stability with EE. So EE together with a strong progestin, it make almost atrophic endometrium and avoid bleeding problems. This is the reason for the good cycle control with the EE-based CUC. These are the pills which we normally use. And this is the reason that we have not this cyclical stability with E2-based CUC. We have a very high frequency of irregular bleedings. But the new-based CUC have good cyclical stability. I have not the time to go in detail why this is, because it was a long time and it was 15 studies to get the correct progestogen and to combine it with estradiol and to get not so much irregular bleeding. The main reason is that when you get the estradiol, maybe from the pill which you give the patient, or estradiol comes from the ovary, or for the E1 S-pool, this estradiol is metabolized within 1 hour to E1. E1 is not strong enough to stabilize the endometrium. We have a breakdown of the endometrium. This makes the irregular bleeding. But if you have a Dionagest or nomegestrol, they make a very strong transformation, the secretory transformation, and we have almost atrophic endometrium. We have stable E2 levels. So the E2 levels with total valorate Dionagest, Lyra is only about 50, and what is important, it is constant, not up and down. This is the reason why we have so good cyclical stability with Dionagest and also with nomegestrol, which the pharmacology in details we have published. And there is one study now which we have that in a decisive factor, the VTE risk, is that we can expect that the new pills with estradiol compared to the pills with ethinyl estradiol may have less thrombotic risk. This study from Dinger was 60% less risk, which was significant of venous thromboembolism. And there are a lot of additional positive effects of the estradiol in brain, in bone, urogenital tract. So we can expect that E2-based pills may be a good alternative. But I have to repeat what we already have heard in the lecture of Professor Mark Birkhäuser, that until now, we are not allowed to change to E2-based pills instead of ethinyl estradiol in risk patients. So we need more study to make this change. But in my view, as I'm also a pharmacologist, I'm very sure that E2-based pills have a lower risk compared to E-based pills. Now, last not least, very briefly, we have a difference in Europe and China. We know the absolute numbers of the VTEs in Western world. We have in the perimenopause about 1 to 1,000, but we do not know any absolute risk in China. It's not known because the risk is very low. And we have done the first observational study to look at the basic risk in China. We could do it because we had 1 million outpatients every year in the clinic and in the Department of Gynecological Endocrinology, about 100,000 outpatients every year. So we have patients enough to test how is the risk with CUC, because from the 500 outpatients coming every day in our Department of Gynecological Endocrinology, about 20% at least at CUC. And they get mostly Dian, CUC with CPA or the drospirenone pill. And we know from the history that the VTE risk of those women coming to us is very low. They mostly, almost no women is reporting about any VTE risk. And when we are together with doctors from other hospitals coming to our compartment for continuous education, they confirm that the risk is low. What we have done is we investigated 100,000 outpatients in written booklets. These are the written booklets in China. And we looked also in the computer. And in the last 5 years, in the computer are 5 million outpatients. And we could almost not believe it, but we have published in Maturitas we see no reported VTE risk as a serious adverse event in computers in 5 million outpatients. And mostly in the women who get the CUC, CPA and dosperenone have been used. We can calculate that we would have at the same time in Germany more than 1,000 VTE risks in 5 million women. And this is based on the numbers which we have in absolute numbers, and is based also in the numbers with different progestogens. So the recommendations for China is indeed we can use combined oral contraceptives because it is an advantage. We can use CUC, they can treat climacteric symptoms and prevent bone loss, have additional contraceptive benefits like avoiding endometrial ovary cancer, and especially we can treat the perimenopausal bleeding problems, which are also very frequent in China. Other recommendations are in Western world. In Western world is the general recommendation of WHO and most guidelines to use progestin-only pills or the implant or the LNG IOT. But we should know that we have, and we should use it because the VTE risk is low, cardiac risk is low, no negative effects in lipids, and no negative effects in weight and blood pressure. However, we have the problems of irregular bleedings, no treatment of climacteric symptoms, no prevention of osteoporosis. So last not least, I think the best choice for Europe would be to add estradiol, and we add mostly transdermal estradiol, so we can also treat the bleeding problems, we can treat climacteric symptoms and maintain bone density. And if we will get more studies about E2-based pills, I think also a good choice in perimenopause is to use these now new estradiol-based pills. So the initial question is, can we use oral contraception in perimenopausal patients? And I would say yes, we can use, especially not in the patients, especially in the women. So thank you for your attention.
Thank you. Thank you, Alfred. Thank you very much. You can now, close the screen, and then we will go to the discussion. We had two lectures, one, the risk woman facing the contraception, and the other, the menopausal transition facing the contraceptive needs. We had a series already of question rising. Please put your question on question and answer, and I will read that one. Okay. We will start with Marcus Sackensmeyer. He was asking risk in long-term MPA only use in patients with hypertension. Did you believe, Martin, that hypertension long-term only MPA use should be a risk?
Well, for depot MPA use, we have some studies showing an increased risk, not for IUDs with LNG. There we have no increased risk. And LNG alone, I think no, but there are not many studies about it. So in conclusion, IUDs with LNG are allowed in hypertension. MPA, depot MPA, I would not recommend.
Thank you very much. And then now from an anonymous, a question to Alfred Müller. According to WHO guidelines for the use of contraceptive in perimenopausal, only progestogen pills are allowed. No combined progestogen estrogen preparation. It is true?
According to the guidelines, it is true, yes.
And then what is your comment about that one?
As I have in my presentation, if you have not patients but women, then you can use it. And if you have patients, it may be better to use the E2-based pills.
Okay, perfect. I think it's important that you give also your comment. And then now another one for Martin. This is from Annette Peen. She asked, a 35-year-old woman with migraine and happy for the pill, can she go on with the pill? Annette, don't mention if this migraine is with aura or without aura. I would like your comment, Martin.
Actually, that makes a difference. If the patient has no aura, she can continue. If she has an aura, I would change.
Fantastic. Okay. And then now an anonymous for Alfred. According to the European guidelines, the EMEA, for the use of combined contraceptive in perimenopause, only COC containing levonorgestrel are allowed. It is true?
It is true for Scandinavian countries where we have people like Lidegaard, and they have a very strong effect in the health authorities. They told me they no longer can use other pills. It is not true for Germany. I do not know the rules for Italy, but until now in Germany, you can use all CUC also with Dymagest and with other pills if there is no special risk. So there is a difference between Scandinavian countries and other countries.
Yes, but as also you know, the COVID-19 is moving from country to country, not looking to the border. I would like to have your believing on that question. What do you believe, looking on the scientific data, that it is the truth?
I think in the scientific data is more important the difference between ethinyl estradiol and estradiol. 90% of the VTE risk because of the ethinyl estradiol. And the arterial risk in normal women is very low. So if there is no arterial risk, it's only the VTE risk, then I would say that we have a problem also with levonorgestrel and EE because of the E. So I would, in the risk patients for VTE, prefer progestin only, like a pill or the IUD, and I would not think that the solution to add the levonorgestrel makes such a difference in the risk of VTE.
Thank you very much. But that way you answer also to Michael Samaha, who was asking estradiol versus ethinyl estradiol and VTE risk. I thank you very much. Then now we have a question for Martin. The question is that one. Which is the most important criterion in diabetic women for the decision if combined hormonal contraception is possible?
I think the most important criterion is the presence or absence of vascular participation. If you have any vascular disease in a diabetic, it is absolute no-go to give a combined hormonal principle.
Fantastic. Then now to another question to Alfred. Sorry. Guideline for contraception in perimenopause should be different in Europe and Asia, especially China. This is true. You have already mentioned that one because it's different the incidence of the disease in China in comparison to Europe. And then what is your suggestion in Chinese patients who live in Europe? Do you have any information about?
We know from other questions in the same questions about risk patients. If the Chinese live in Europe and live not long time, then the rules are for China. If they are a long time in Western world and have the diet in Western world and other things which are in Western world, maybe after 5 to 10 years, then the risk is more like in the Western world. Now it depends how long they are living in Western world, and it depends, of course, also of the risk, like VTE risk. I think it will not change because the VTE risk in Western world mostly based on clotting problems, clotting factor problems, and we have no clotting factor problems in China until now. We are checking this. If you are asking a Chinese expert, high-rank expert, what is a factor V Leiden mutation, maybe he doesn't know it because it is not tested. ABC resistance is not tested yet. So this is the difference, and genetic differences will not disappear if Chinese go to Berlin.
Thank you very much. And then now a question from Edda Pasinetti to Martin Birkhauser. Is atrioventricular block a contraindication to the contraceptive? And in this case, which is the best contraceptive method?
I think we have to always consider that if you have an AV block, you have this completely discoordinated action of the heart, with the increase of coagulation within the heart itself. And that means that you can have an embolism to the brain. And for that reason, all principles increasing coagulation by the contraceptive method are a no-go. And for that reason, combined hormone contraceptives are not allowed. Other principles, positive-only principles, can be given, as well as, for instance, IUD with LNG.
Thank you. And then now for Alfred Muck, a question from Silvia Caposci-Coxi. She asked, what is your opinion about estradiol for perimenopausal women?
I think it is maybe a good choice, but we still need more data about this, especially in risk patients, like with increased risk of venous thromboembolism. So I think we need, especially in risk patients, more data, which we have with the E2. So we know much about E2 and risk, but we do not so much know about E4 and risk. So especially in risk patients, I would be careful.
Thank you. And then now a question for Martin. This is mostly based on the data that you showed that intrauterine copper contraceptive, they have normally a rate of 1. The question is from Oscar Shimange. Do you think in present medical practice there is still use for copper-based intrauterine contraceptive?
Well, now, first of all, how are you, Oscar? Long time that we didn't meet. The answer is that there is still a place for copper IUDs in patients at high risk. In all other patients, I would prefer LNG IUDs. But if you have to avoid any risk at all, copper is still a solution.
Thank you very much. And then now a question for Martin. She's originating from Sheikh Zinat Nasrin, and he or she, I don't know the name, if it's a woman or man, she asked, how long oral OCP need to be continued or just menopause lady? And what is the risk of breast cancer from long-term oral contraceptive use?
Well, I would like to pass the first part of the question to Alfred, who treated this subject. For the second part, the data are contradictory. There are some data showing no risk increase, other data showing a small increase in younger patients, others showing an increase lasting up to 10 years and then completely disappearing. So to put it short, I think the risk is so minimal, if there is any, that we can use the pill without restriction.
And then now, Alfred,
the question is about
how long OCP can be continued in a perimenopausal or just menopausal woman?
If there are no additional disease and no special high risk factor, it can be continued until we know she can no longer be pregnant. So we continue up to 52 or 55. So if no risk, no additional risk, I have no problem. But there's a difference in Scandinavian countries. They are very cautious about this, and they mostly recommend the progestin-only pills. But in my view, you can, in patients who have no additional factors, or maybe only obesity and no other factors, you can continue up to the age where you can no longer have pregnancy.
If I add one thing, Andrea, I think Alfred suggested an excellent solution, and I would like to come back to this. You can use LNG IUD and add estradiol 17 beta as a patch. Then you are safe.
Yes.
Okay, and then another question, that one is also for Martin. Which contraceptive method has the lowest metabolic risk? Diaphragm, condom, fertility awareness-based method, sterilization, vasectomy excluded. Not this one, but or the other.
Well, this question makes an allusion to what we said before about the copper IUD. If you want to have no risk at all, I would say for metabolic risks, then we use the cup IUD. But for the normal patients, of course, the LNG IUD is better.
Okay.
Did I answer your question?
Yes. Okay, and then now a question for Alfred. And then since estradiol-based COC have shown to have lower VTE risk compared to COC containing ethinyl estradiol, VTE in history is no contraindication for estradiol-based COC. It is true.
It is still a contraindication according to the labeling, which I have to show you in one slide. But it is according to the study of Dinner, you can use it. So it is just now also according WHO contraindication. And just now WHO makes no difference between EE derived contraceptive pills and E2 derived. But I think this will change.
I think that we have now a question that I will ask first Martin and then Alfred. It's a both question. Question to both from an anonymous. What do you think about estetrol? Do you think this could be an option in premenopausal women or in women at higher risk? For the higher risk, Martin, and for the premenopausal, Alfred.
I think that could be a solution. It seems to me an excellent estrogen to be used in contraception, but still the clinical data are missing for high-risk patients. But I would say in the future we'll be allowed to use it for these patients.
I think I would add really we need more data with E4 in special risk patients.
Yeah.
So when I compare E4 with E2, I will prefer E2 because E2 is the normal estrogen. So I think E4 in risk patients may be a problem.
Yes, I think that we don't have sufficient data about that one. Also because the majority of the study have been done, you know, for registration. And then they have been done only in very healthy individuals. While normally pregnancy, where estetrol is very high, occur in everybody, also in very high risk pregnancy. And then in that view, I agree with you, Alfred. But I will be cautious because in nature, estetrol seems to protect the woman in general. But now I have a question for Martin, which is the preferred hormonal contraception in patients with rheumatic disease?
That depends if we have a complicated rheumatic disease with antiphosphate antibodies or not. If we have no antibodies, then we can use combined hormone contraceptives. If we have the presence of these antibodies, it is strictly no-go.
Thank you. The question was raised from Sandra Gomez Ramos, and I would like now to mention that I was not aware about the names, and Sheikh Zinat Nasreen, who have put the question before, she's a lady from Bangladesh. Then now a question to Alfred. Main problems of estradiol-based COC are decreased contraceptive efficacy and frequent bleeding problems. Is this true?
Bleeding problems are a main problem in the older E2-based preparations. But if I understand the question correct, the two E2-based contraceptive pills, one is with the Dienogest and with Normagestrol, have a very good cyclical stability. And if we have bleedings, we see mostly the bleedings out of atrophic endometrium. So when I have a patient who is bleeding, say with Clara, I mostly can stop the bleeding giving E2 patches in the days of the bleedings. So if I understand the question, bleeding problems have been a real problem in the development of E2-based contraceptive pills, but they are no longer a real problem with the two pills which we have, with the exceptions. And the exceptions mostly are bleedings out of atrophic endometrium.
Yes.
And if the endometrium is totally atrophic, so we have some patients with Dienogest, which has a very strong atrophic tendency, I sometimes need another things to stop those bleedings. So we use other things to stop those bleedings.
And please, what you use, because this is something clinically important in this kind of, not of very frequent, but existing patients, what is your attitude? You increase the estrogen?
We give constant estradiol like a transdermal patch, and this can stabilize the endometrium, but it must be given in a constant manner to give stable endometrial levels, stable blood levels and stable levels in the endometrium. So with transdermal estradiol, we can stop those bleedings out of atrophic endometrium.
Thank you very much. You have any comment, Martin, on that point?
No.
Okay, then a question for you. The question is, do you control cholesterol and triglyceride level on COC? And eventually, how frequently?
Well, there is excellent, how to call it, a table made by SCORE that is measuring blood pressure, weight, and cholesterol only with triglycerides. And with these three factors, you can predict very precisely the risk for cardiovascular events. I think if you measure these three without triglycerides, you can estimate the risk quite well in quite a cheap way. If you have a suspicion by family or by the habits of the patients, the alimentation, then triglycerides can be added, but not necessarily. That's my opinion.
Thank you. You have any comment, Alfred, on that point?
We only make, we only test it if there is a risk patients in cardiovascular disease, not in normal women.
Okay, then I have a question for you. What is the estradiol equivalent dose to 30 micrograms of 18-yl estradiol from Michael Samaha?
It's about 1.5 milligram the E2 or 2 milligram E2 valorate.
Okay, then now we are approaching to the end because the time is moving on. I thank you. We have still 150 participants with us. And then I want to have a question now for a question now on this is a special case. Rekha Vuntakal asking a patient on lamotrigine, and what is the real best pill to give when they decline Mirena and Depo?
Lamotrigine is very special. It can the interactions with lamotrigine can go in both directions. You can have an increase of the cytochrome P415 system and a decrease, and it is dose dependent. For this reason, we estimate the lamotrigine levels. So what I would recommend would be if they do not use the LNG or no IUD, I would use an E2-based pill.
Okay, and then now we have a last question because we have a comment. Martin, yes, please.
A question to Alfred. Couldn't we use a POP if the patient doesn't want LNG IUD?
Progestin only pill, it can depend on the progestin, the interaction, because some progestin have an ethinyl group. Progestin do not. And progestin with ethinyl group can, from the pharmacological point of view, make an interaction like ethinyl estradiol. So with lamotrigine, if we use POP only, we cannot use the normal desogestrel pill because desogestrel have an ethinyl group. But we could use a CMA off-label, for example, which has no ethinyl group. So it depends on the pharmacology of the progestogen.
Thank you. And then now another question, Martin, probably for you. This is from an anonymous 25-year woman, 25-year, with bariatric surgery, gastric bypass, heavy and prolonged menstrual bleeding, no good response with oral combined contraceptive, rejects the use of Mirena. What is your suggestion?
I have no solution, but a suggestion. I wonder if the patient cannot resolve normally both components of the pill. So I tried to use a non-oral principle of CHC. Perhaps that works.
Okay, thank you. Then the last, but we have always, we need the last question. That one will be for Alfred. Do you, this is from Samir, do you use progesterone daily for perimenopausal women, and for how long?
As I told you in my lecture and presentation, I would prefer E2-based pills because progestin only makes so many bleeding problems. Or we use it together with transdermal estradiol patches cyclically. So sometimes we give in a cyclical way the transdermal patch to get regular withdrawal bleeding, with estrogen withdrawal bleeding, and we can use the progestin only pill without such many bleedings.
At the end, because it's quite late. And then I have to comment, one from Marina Bignard de Halla, congratulations for the lecture, and one from Mary O'Flynn, thank you all for an excellent webinar. And then with that one, thank you very much, dear friends. And I think we have to conclude this session with the satisfaction that the focus on difficult patients in contraception with high health risk done by Martin, and how to face perimenopausal time and contraception done by Alfred, they have not only given the answer on that, but they haven't given the answer to most of the daily problems that we have in our clinical practice. And then I wish for Martin all my compliments, and also for Alfred. And I invite all of you for the next fantastic webinar, which will be on a very interesting topic, which is disorders of sex development and endocrine conditions, impact on sexual function. It will be the 8th of October, always at 3 o'clock Central European Summer Time, done by Angelica Hirschberg from Sweden and Rosella Nappi from Italy. I invite all of you to come and to join with us. And with this in mind, I remember you that the next ISG Congress will be from the 2 to the 5th of December 2020, and will be a fully virtual Congress. It will be everything online. It's a fantastic event. You will see a huge number of presentations. All free communication will be left available for everybody in the world. Poster will be left available for everybody. The other material will be available only for registered people. I invite all of you to join us from the 2nd to the 5th of December at Virtual Congress of the International Society of Gynecological Endocrinology. Goodbye, dear friend. We will meet very soon. Bye-bye. Arrivederci. Arrivederci.
Bye-bye.